please subscribe and don't forget to press the bell icon to get notified whenever we upload a new video.
Well, the key showpiece of this year's budget was the very ambitious National Health Protection Scheme, or Ayushman Bharat, that aims to provide quality care for 10 crore poor families, most of whom have had no access to medical insurance up till now. As the government readies to roll out this game-changing scheme, it is time for a status check on design and blueprint of the National Health Protection Scheme and the 1.5 lakh wellness centres that the government plans to set up as part of this mission. Welcome to CNBC TV18. I'm Shireen Bhan, and joining me on the show to take this conversation forward, Dinesh Arora, Director in charge of Ayushman Bharat at the Niti Aayog. Also with us, Pranam Mohan, Investment Officer, Health at the International Finance Corporation, or IFC, and Abhay Agarwal, Partner, Government Services at EY India. Gentlemen, appreciate you joining us here. Dr. Dinesh, let me start by asking you, it's been a little over a month since the budget was announced and that big announcement came in. Are the nuts and bolts coming together? Give me a sense of how many meetings have taken place on the scheme, for instance.
Thank you, Shireen. I think I'll just like to clarify that Ayushman Bharat has two components. One is a comprehensive primary health care, which is the foundation one, and overbuilt up is a secondary and tertiary treatment, which was National Health Protection Scheme. And this is, let me tell you honestly, a historic moment. For the first time, we have such an emphasis on social sectors, especially on health. Primarily, everyone in the ministry, Niti Aayog, is excited about it. And every day we are having meetings, discussions, deliberations with the state governments just to roll out a design for implementation of this scheme.
Right. So in terms of design, implementation is much later, but in terms of design, where do things currently stand?
The scheme was announced on 1st of February. After that, on 15th, 16th, we had the major event of state-level consultations. Every state was available, participated, except Tripura, which was having elections.
Okay. So West Bengal was part of that meeting, is it?
Absolutely. Okay. In fact, West Bengal had their secretary presented on the IT front also, like what they have done. Now, we must understand that these consultations were meant to exchange ideas, to exchange best practices and put forward first. Then we also had meeting with the insurance companies in the ministry. So we are working on it, on track, discussing, deliberating before we roll out the design of the scheme.
Okay. By when can we expect the design of the scheme to be rolled out?
Very soon.
Give me a timeline. Very soon could mean anything. It could mean tomorrow, it could mean a few weeks, it could mean a few months.
Once the cabinet note gets approved, we have the design of the scheme ready.
Okay. And where are we in terms of getting the cabinet note ready?
Very soon, as early as in this month, I can say that.
So the cabinet note for the scheme should be ready as early as this month?
Hopefully, we should be able to get through, yes.
Okay. I'll come back to you. I have many more questions, but Pranam, let me ask you now. And you know, there are several questions that remain unanswered at this point in time, and I would imagine that we'll get clarity as we get the design and the blueprint from the government and the Niti Aayog. What are the key concerns that you have? Because this is going to be a volume play. This play also has two components. One, of course, is the insurance component, and the other is the care component, as Dr. Dinesh was just articulating for us. As the IFC, what is it that you would like to see the government put in place to ensure that this is viable and sustainable?
I think, first of all, this is one of the most promising schemes that has been announced in the health sector in a long time. This has tremendous promise, not just for the people, but also to develop the health sector in the whole country, not only in the short term, but even in the long term. From the IFC perspective, we don't really have concerns, but we would like some specific areas to be focused on. Importantly, the focus of areas of focus should be quality of care, as well as ensuring that the tariffs are reasonable and make a case for sound financial investment plan.
What is viable? What is a viable tariff according to you? Because as I pointed out, this is largely going to be a volume play, and the government is hoping because of the large volumes, they're going to be able to drive the price down. What, to your mind, in your assessment, is likely to be a viable tariff?
So tariffs are some of the most complicated components of any of these kind of programs. And tariffs will depend on different areas. Some states may have lower tariffs than other areas. Some areas within states themselves may have different tariffs. But the main concept should be that whatever treatment is given, that should be given at a cost that is recovered by the private sector or whichever provider hospital is providing that.
Absolutely, otherwise there's no incentive for them to come on board. Dr. Dinesh, if I could ask you that, because, you know, people are asking questions on, A, what is this going to cost the government eventually? You know, we had a allocation of 2,000 crores as, which is really the RSBY allocation as part of this scheme, which the Finance Minister announced in the budget. What is it going to cost? We've heard numbers like 11,000 crores, 12,000 crores, 30,000 crores. Now that you've had several rounds of meetings, what is it going to cost?
We had discussions with the states, we have discussion with the insurance companies. Let me tell you one thing, that it's a very thought out scheme. We have the experience of running of RSBY for last 10 years. Nearly 24 states were running some part scheme there. So we have a lot of experiences. So as far as tariff, I mean, you want me to say the premium, right?
Yeah,
insurance premium.
The tariff for the procedures performed under the
so he's talking about the packages.
And you're talking,
So we are very clear on the package rates. We have a committee headed by Director General of Health Services, which has representative of 7 or 8 states. So we have rates defined. Then we have a peer review by the Niti Aayog, handed by Member Health, so that we have a total definitive picture, and then we share with the states. States, on their flexibility, can lower their rates. They can increase their rate to a certain bandwidth only. So as you said, this is going to be a very flexible scheme. Packages, we will have an indicative packages, exhaustive indicative list of packages, and then states can modify depending on the local situations. For example, situation may not be same in Northeast, may not be same as in Tamil Nadu. So states can increase to a certain extent, but they can decrease as much as they want.
Okay, so coming back to cost, what is it going to cost the government?
Shirin, let's not jump the gun. The market will discover the rates.
Okay.
So we had an interaction when we called the insurance companies. 24 insurance companies participated in a short run. Notice was for 3 days. Many of them couldn't come. So there are about, if I'm not wrong, 30 odd companies in this non-life sector, and 24 were participative. Tender rates will be discovered after the bidding. So let's hope that we get the best rate.
Okay, so you're saying that the rates will be discovered through a market process, through the bidding process. But there must be a ballpark number that's on the table at this point in time. I mean, what are insurance companies telling you what will be viable for them?
Insurance companies didn't have much hassles on this. They had certain other issues which we were trying to sort it out. Like they wanted that, you know, the premium cost should be paid to them on time. The states should give them money on time. And how do you have a system of IT coming up? How do you have the frauds controlled up? So there were the discussions. I'm sure even they are aware that it's a market-driven price, and whatever they are going to bid for it. So market will discover the price. The best price will come out if we are doing in a transparent, holistic way.
We are given to understand that Nandan Nilekani's support is being enlisted for this scheme as well. Can you give us some sense and some idea of what we should expect on that front?
Right. So IT will become perhaps the most critical element here, whether it's for claim settlement, for Aadhaar seeding, or for your fraud checking, or for your grievance redressals. Now, for IT, we have the Health Secretary has formed a committee under Mr. Satyanarayan, T. Satyanarayan. He's the chairman of UDI, and he was a former Secretary IT. And we have representative of the states. So the committee is working on it. Yes, we have also enlisted the support of Mr. Nandan Nilekani also, to take his experience also. So for IT, we have a detailed approach, which will be very soon out. We are working on this, and we also realize that IT perhaps is the most important element in this whole chain of you know, your hospital empanelment or Aadhaar seeding or package design, which we are working on.
Okay. And by when can we expect the IT blueprint to be sort of made public?
Should be by 15th of April.
By 15th of April?
Blueprint, yes.
Okay, 15th of April, the IT blueprint should be made public. The RSBY, what have been the lessons and the learnings learned from what has gone wrong with the RSBY? Because you know, there is an acknowledgement on the part of the government itself that it didn't really reduce the out-of-pocket burden on the end consumer. So what have been the lessons from the RSBY that you hope to now rectify as you design this scheme?
Well, we should give some credit to RSBY. RSBY was the first insurance scheme launched in the state and for the labor sector. So it had a different goal. And perhaps it also motivated other states to launch their schemes. So in that way, it was pioneering. I think the amount 30,000 was partly. It had a size limitation of 5 per family. So that means perhaps the woman or the girl child will be marginalized. Then it didn't have at that time, perhaps the technology was not evolved. It was a desktop-based server, not an API interface technology, which we are looking forward to.
Okay.
So these were, and the one thing which was that it was an enrollment-driven scheme. You have to get enrolled to get the benefits. Now, from day one, this scheme is an entitled-based scheme. So whosoever are entitled by SECC, from day one, they can avail the benefits. I think these are perhaps the major learnings which we have taken from them and put up and dovetailed in the new scheme, improved upon them and dovetailed in the scheme.
Okay, so this one nation, one scheme will be a flexible one if the design that he's talking about goes through. But what do you see as being the big challenge of executing this at the state level?
I think there will be two big challenges. One is health is a very state-specific, even region-specific issue. So the scheme should be fairly flexible enough to ensure that the states can modify it sufficiently enough to meet their needs. And the second issue that we have seen in the states that we have sort of worked in is the ability of the states to have the technical capacity to implement these kind of programs. States typically lack the very specialized knowledge skill set that is required. So probably the government should be also focused on supporting states in developing a long-term technical facility or capacity within the state governments to implement. That would be crucial.
The state schemes are largely enrollment-based. This is going to be entitlement-based. Your catchment area is going to be very different as part of the NHPS from the existing state schemes. So in terms of convergence, I mean, practical challenges on the ground, how do you intend to cope with those?
Most states were very open. I'll give you one example, say Tamil Nadu. Now, Tamil Nadu has a scheme of, say, 2 lakhs per family. Now, this scheme, which is done by the government of India, is huge, 5 lakhs, which is given up per family. So how do they do it? Either they negotiate with the same tenderer, or they do follow the trust model there. From insurance, they go to assurance model for there, from 2 to 5 lakhs. So most states were very keen, and they are devising their own transition method, how they will figure in and how they will join this government. So perhaps they need their own clearances, their own mandates. So we had a first round of discussion. Very soon we'll have a second round of discussion with them.
A second round of discussion with states. All right, we'll take a break on that note, gentlemen. We continue to discuss the nuts and bolts of the Ayushman Bharat scheme. That was the big budget announcement. It's also popularly now been called Modi Care. We'll talk about that and more when we return. Don't go anywhere. Welcome back. You're watching Iron India, and we're discussing the Ayushman Bharat scheme, or what is popularly called Modi Care. We've just heard that a cabinet note to put the nuts and bolts together could be finalized within the month. That's the expectation at this point in time. At least that is what the Niti Aayog is working with. Let me ask you again, as I pointed out, we've had all kinds of numbers from 11,000 crores, which is the number that Niti Aayog has given us, to 30,000, to some people suggesting it could cost way more than that. What is the broad estimate? And I understand that there will be a tender process and so on and so forth, and the market will determine. But how much is this going to cost the government?
Sheena, I'll just like to say one thing on the part of the government, that whatever the expenses come, government is fully committed. And this is going to be discovered by the market. So I don't want to preempt any figure, what figure will like to come. But I'm sure it should be like whatever the market discovers, we will go forward to it.
Okay. Also, how is this going to work now? The Niti is responsible for design in terms of IT execution, etc. I mean, who all are going to be the cogs in the wheel, so to speak?
I think, let me tell you that this scheme will be a symbol of cooperative federalism. It doesn't work department-wise, Niti or health, no, it's all a government thing, and we are working together, whether it's Niti, whether it's health ministry, together for this scheme and in partnership with all the states. And yes, Niti is helping us in IT and delivering getting the IT model ready, and the other things are also getting ready. So it will become a symbol of cooperative federalism with states, all the departments of the government, and all working together to make this breakthrough, to make this scheme a great success.
Launch date, the rumor was October. Is that when we're likely to see this being rolled out?
We are working day and night. This is in partnership with states. So we are nudging the states. As soon as the states get ready, we should be implementing this. Okay,
one of the things that perhaps hasn't got as much attention is the wellness center piece, which is a critical part of the mission as well. 150,000 wellness centers as part of the scheme that the government is talking about. Abhay, let me start by asking you about what you see as being the impact and the implications of that.
So I think the details will have to be seen, how this is being rolled out. But with the past experience, I think government will try not to do a brick and mortar new infrastructure. Existing infrastructure, they will try to build as much as possible, because I think time is the essence of the whole thing. And this insurance will also be successful only if the healthcare infrastructure is kind of expanded. But the supply of doctors and nurses is not going to really increase in that proportion. And going to rural areas will be challenged. So it is full of challenges. I think in terms of doing it, now technology and private sector, that is the only two options. Because only technology use and private sector efficiency of rolling it out very fast, these can surmount the problem of wellness center. So we will see. I think a lot of things are happening already, and you have a lot of new technologies which have come in the market, which can actually, where the doctor sitting across, at a distance can see all the reports, etc., and prescribe, and only few cases can move on.
So can you give us an update on where things stand on the wellness centers, and what is the plan?
I'd like to say something here. Let's not discount that under NHM, a lot of good work has happened in the public sector, especially the last 3 years. Huge money has been pumped in to improve district hospitals, CHCs, taluk hospitals, medical colleges. Even in this scheme, 24 districts are going to be converted into medical colleges. We have the medical college division, which is working totally on improving the infrastructure. Many aims-like institutions are coming. So government has very consciously taken a call when it has been trying to do its best in improving the infrastructure in the public sector. And now where we are moved towards a demand-side financing. Yes, technology is an important part, and technology will always remain an important part. And how we inbuild technology to get efficiencies is a challenge, and both a challenge and an opportunity.
But on the issue of existing infrastructure, new infrastructure, I mean, what can we expect in terms of the roadmap for the wellness centers?
I think wellness center perhaps is going to change the way we look at the health department. So they will eventually become the gatekeepers. They will eventually become, if a person has to be referred, they go through the wellness centers, their electronic health records get generated. When they get the treatment done, they come back and they are followed up at the wellness centers, primary health care, or the sub-centers level. So that's the design. And let me assure you one thing here. It's not about infrastructure. It's about human resources. It's about imaginative thinking. How do we use human resources? How do we use technology to get the best out of them? That's being worked out.
Okay. So the health stack, I'll end then by asking you about that. Can you give us some sense of how you intend to leverage the health stack, which I also understand is going to be a critical component of getting this scheme to work?
Well, that's a long-term plan of putting up a health stack. Health stack basically is derived from what the government has already done, but the India stack, about your JAM Trinity, about the 1 billion cube of mobiles, Jan Dhan accounts, as well as Aadhaar. So built on similar design, we think we should have a health stack where you have registries of the providers, the hospitals, including the doctors. And then you build up any architecture. Today, because Aadhaar has been great, eKYCs everybody uses. You get a mobile phone, you don't have to put any documents. Just put your thumb and your KYC is done. So that way we want to have a national information utility where it could have the health stack ready. Anybody can ride over it. Examples are there. Whenever the government has done great, everybody has used that. And this is one of the things. It's a proposal. Let's see how it fructifies in the future.
Okay. Wrap-up comments. I'll start with you, Pranav. Next steps, what will you watch out for?
I think we'll watch out for the launch of the scheme, and more importantly, Dr. Dinesh also and Abhay also mentioned, lack of infrastructure will also critically become a bottleneck if the scheme becomes successful. And the government will have to come up with a plan to sort of ramp up the infrastructure. We lack around 500,000 hospital beds right now. So how do we develop those hospital beds in the next 5 to 10 years? That also has to be planned.
Quick
I think this scheme will become a fulcrum of reforms.
Okay.
The challenge is if we can get back the money as claims to the public hospitals, this scheme entails that the money will be spent only in that institution. So, for example, a hospital in Rangareddy should get ₹1 crore every year only from the insurance claims. Build up their infrastructure, build up their human resources, build up their labor rooms, and then deliver the services. And that will become the barometer of actually ranking hospitals. It's not only cooperative.
Which is what the NITI is looking at doing now.
Not only cooperative and competitive federalism, not among states, but even among hospitals, including public hospitals.
Right. Ranking of public hospitals is what the NITI Aayog is working towards. Abhay, final comment.
I think incentive and motivation for existing doctors and healthcare providers in public hospital is going to be very, very key. today they are doing X, tomorrow if they have to do 1.5, 2X, and they have also to be very active, as good as private sector, and they have to attract, because it is going to be a demand side push. We have to have some method where they also get the gains. That is one thing. And second thing is, of course, a demand side push will also ensure that many private infrastructure come.
Okay.
And that will be key, because private infrastructure, doesn't take that much of time. And that's what we have survived on for the last 15, 20 years, because public infrastructure has not really expanded in the same fashion.
Okay, we've talked about the opportunities. The number one challenge, and I'll end with that, the number one challenge that you see now that you've been doing this for the past month or so.
I think it's a great opportunity. I think we just need to work towards it, be positive, and deliver it. I think the country becomes this. This is a great scheme which has been announced. The government has done its bit. It's for all of us now to make this scheme, whether it's public, whether it's private, whether the common citizen. Imagine what this scheme has done. A common man having entitlement of 5 lakhs gets into any hospital. We are nothing but moving towards universal health coverage, and if I'm optimistic, even a right to health. Give me my health. This is the money the government has put in my account.
Okay, right to health. Perhaps this could lead the way to that. Thanks very much to our panel for joining us here today to take us through where things stand as far as the big budget announcement was concerned, the Ayushman Bharat scheme. We've got plenty of news here that Dr. Dinesh has given us. We'll chew on that, and of course we'll give you constant updates on where things stand on this scheme. But for now, from all of us here, goodbye and many thanks for watching.